My name is Austin Page. The date is July 16th, 2019. And this is my video submission for the Unit 2 Case Connections video presentation, assignment for medical biochemistry. So the first case I will be discussing is Case 2, regulation of glucose uptake by the cell. There are two images side by side that are posted, both an MRI and a PET scan. Illustrating the same brain. So on the left is the MRI. It shows a large glioblastoma tumor with areas of necrosis within the tumor. The PET scan was taken following the administration of fluorescently labeled D-glucose, which is necessary to observe accurate brain activity for optical imaging. A glioblastoma is a highly invasive glioma in the brain, a glioma being a malignant tumor of the glial tissue of the nervous system. And necrosis is a term attributed to the death of cells in an organ or tissue. So necrosis is an authentic feature of glioblastomas due to their aggressive and invasive nature. As for glucose uptake, it is regulated differently in the brain, liver, skeletal muscle, and adipose tissue. The brain is the only one specifically regulated by glucose transporter 3, or GLUT3. Although this transporter does appear in various tissues, it is most explicitly expressed in neurons. So the liver is regulated by GLUT2, while both skeletal muscle and adipose tissue is regulated by GLUT4. The difference in glucose use and uptake between normal cells and tumor cells is illustrated by the Warburg effect. And the Warburg effect states that cancer cells have different or altered energy production in comparison to normal cells. Normal cells have a lower glycolysis rate, whereas cancer cells have a much higher glycolytic rate, roughly about 10 times faster than that of normal cells. It also details that glycolysis in normal cells is followed by the oxidation of pyruvate in the mitochondria, in contrast to aerobic glycolysis in cancer cells, which is followed by lactic acid fermentation even in the presence of oxygen. The extremely high glycolytic rate of cancer cells results in the overproduction of glycolytic enzymes, such as hexokinase 2. In turn, the glycolytic rate is further increased and more energy is supplied to cancer cells. 2-deoxyglucose is acted upon by hexokinase due to its similarity to glucose, creating 2-DGP, which cannot be metabolized by phosphoglucoisomerase and thus stops glycolysis, reducing ATP production to 2 molecules of ATP for each molecule of glucose rather than the standard 36 via oxidative phosphorylation. This may seem counterintuitive, but there's actually a benefit to only using glycolysis. So many cancer-associated signaling pathways induce metabolic reprogramming, and there are target genes that are affected by HIF, or hypoxia-inducible factor, that decrease the dependence of the cell on oxygen, while at the same time can also upregulate glucose and consumption and glycolysis. So reforming metabolism to only using glucose is advantageous to cancer cells since it offers them the ability to execute the biosynthesis of macromolecules and avoid apoptosis. Cancer cells consciously reprogram their metabolism to promote long-term survival and may change their metabolic phenotypes to adapt to microenvironmental changes, resulting in a selective advantage to cancer cells over normal cells. So the next case I'm going to go over is case 4. And there was a prompt in this case that details a health issue of an infant, followed by a list of 4 different diagnoses, only one of which is correct. So I will quickly read through the prompts in each of the 4 options before explaining which is correct and why the other options are incorrect. So the prompt is as follows. A previously healthy 2-month-old female presents with jittery spells several hours after breastfeeding. Her mother reports she has not given the baby anything to eat other than breast milk since birth. The baby has only recently been sleeping for more than 2 hours between feedings, and that's when the mother reports these symptoms started. Laboratory results are consistent with hypoglycemia, or low blood glucose, and are otherwise unremarkable. Epinephrine is administered and there is no increase in blood glucose, but there is an increase in blood lactate. Physical exam reveals a liver edge of 4 centimeters below the right costal margin. Percussion of the right chest and abdomen confirms hepatomegaly, or enlarged liver. Blood glucose levels increase after breastfeeding, but she cannot maintain blood glucose levels within a normal range during fasting. So based on the information above, which of the following is the most likely diagnosis of this patient? Answers are A, hereditary fructose intolerance, B, galactosemia, C, glycogen storage disease, or the inability to use glycogen, or D, glucose 6-phosphate dehydrogenase deficiency. So the correct choice listed here would be C, glycogen storage disease. So glycogen storage is the only option that matches all the listed symptoms, such as the enlarged liver, hypoglycemia or low blood glucose, also synonymous with irritability in the form of sleeplessness, and high lactate level in the blood. So option A was hereditary fructose intolerance, and that is characterized by nausea, vomiting, abdominal pain, hunger, flatulence, shakiness, malabsorption of nutrients, and chronic fatigue, none of which were indicated by the infant except shakiness, from the mention of the infant's jittery spells. Also, there was no issue for the infant in breastfeeding, and that should obviously rule out the possibility of a fructose intolerance, since breast milk is composed of the monosaccharides glucose and galactose, and thus would create digestive issues in the case of intolerance. Option B was galactosemia, and that also illustrated by vomiting, as well as a distinct lack in appetite. Convulsions, poor feeding, poor weight gain, jaundice, and irritability. Neither of these symptoms were shown by the baby except, again, irritability, which is not uncommon in any of these conditions. More importantly, those with galactosemia cannot tolerate any form of milk since it contains galactose. Therefore, the infant would have obvious issues from breastfeeding, and there were none mentioned. Lastly, option D, G6PD dehydrogenase deficiency, includes symptoms of premature red blood cell breakdown, fever, fatigue, dizziness, jaundice, paleness, rapid heart rate, and shortness of breath. None of these coincide with the infant's condition, and therefore this can be ruled out as well. In conclusion, glycogen storage disease is the ailment that has the most symptoms in common with the infant state, and there are no symptoms evident that would rule out this option.